And thank you very much for joining us here on PM Express. This evening, I'm talking to the Chief Executive Officer of the Korle-Bu Teaching Hospital. He is Dr. Opoku Ware Ampomah. And the Korle-Bu Teaching Hospital is a place where we all, one time in our lives, will end up because it's a premier hospital. I have been here many times, and it's a privilege to be talking to the Chief Executive of this great institution. Thank you, sir.
Thank you
For joining us on PM Express. Because it's a hospital, I need to start by asking you, what's the health status of Korle-Bu Teaching Hospital as we speak right now? How is Korle-Bu faring?
I think Korle-Bu has got its challenges, but I think it's doing very well within the circumstances. As you know, it's a 100-year-old facility, but then it's got the biggest collection of medical minds in the country. And I can say within the African region, it's one of the best hospitals in the whole of Africa. And so Korle-Bu has got a very rich legacy, has impacted many lives over the course of the last century. And we continue to make strides to try and improve upon our service delivery, our stakeholder satisfaction, our capacity to deliver on our mandate, which is service delivery, training, and research. And so Korle-Bu has come a long way. We are grateful to our, the government and also our stakeholders, many benefactors who have come to support the institutions at various points in time to help us to keep, expanding in terms of our capacity to deliver high quality healthcare.
You said 100 years.
Yes.
That's a long time to be alive for an institution. And this is the year where you turn 100.
Actually, we turned 100 on 9th October 2023.
Okay.
And so we have a year-long centenary celebration program, so which we've been rolling out. And so we came out with a document which is called 100 Ways to Celebrate 100 Years. And so this has various programs and activities meant to mark the centenary of Korle-Bu. And it has quite a number of also key projects within it, which would help to position us, as the preferred, tertiary hospital, that people can go to seek for healthcare. So we've done quite a number of things over the course of the year, and there are some more that we are rolling out.
Let's talk about that, because I believe from what I hear you say, you want to use this 100 years as an opportunity to rejuvenate the environment, the Korle-Bu Teaching Hospital.
Yes.
That, from walking around, will be a monumental task. How are you going about this?
Yes, so we've tried to break it down into 100 different activities. So the first one is the Adopt Award campaign. So there are a number of awards that are old and probably in a state that can do some refurbishment, renovation. And so we've partnered various corporate entities, individuals to come and partner the hospital to renovate these wards. And so we have had a number done so far. So if you go to a surgical block, for instance, the sixth floor was renovated by Societe Generale, the first floor by the Stock Exchange, I think, Reverend Obama's outfit, and then the second floor by the Kote Papa Field Foundation. And then you go to the children's block, Dread Masters took one floor and renovated it. Ghana International Bank Foundation also has renovated one floor. There's an individual who did some renovations in the cardiothoracic ward. And then we've had the plastic surgery wards have seen some renovation. And so we continue to encourage individuals and groups to partner with us, to undertake some of these projects. So these are, the Adopt Award campaign. And then we also have some critical infrastructure that we also want to introduce. So like the 24-hour pharmacy, for instance, because our current 24-hour pharmacy is small. And then one of the challenges we have is that when you are an outpatient and you are given an NHIS prescription, you have to actually go to one of the pharmacies across the street to get your prescription. But I want to be able to...
But why is that?
Yes, because the hospital doesn't have the physical space and to be able to cater for this outpatient, and we have a 24-hour pharmacy, but that's like a retail space, So we are putting up this structure, that's a 24-hour pharmacy, and thankfully the government has come on board to support us to put up this infrastructure. So he's set up a committee consists of individuals and then members of the Korle-Bu leadership to do the fundraising, start to come up with this. To get this project on the ground. It's going to cost about $7 million, and but we think that it's a worthwhile project because it's going to expand our 24-hour pharmacy. It's going to provide NHI pharmacy services. It's also going to have some supermarket retail space, because if you come to Korle-Bu and you are admitted out of the blue and you need to buy maybe a toothbrush or a few other things, you need to have a place where you can get these things within the premises. And so we're catering for that. We also have some retail outlet space and then some restaurant space as well. And then a place for the ATM, so that those who want to use their bank cards to draw money from the ATMs can have a safe and convenient place to do so. So that facility is also one of the new projects that we want to undertake. We also want to undertake what we call a legacy project, because this is a teaching hospital. And so the teaching hospital, one of our core mandates is training and research. But then if you look around, we don't have any significant auditorium or conference facility. So if you want to have any conference, you usually have to go outside. But I feel that because of the number of different specialties that we cover and the number of training activities that are going on, it would be good to have an in-house facility like that, which is fit for purpose, which also have like a skills center. So this complex is going to be a learning skills and a research center, so that to support research, to have telemedicine or teleconferencing facilities, etc., to enhance the learning environment. So that, because Korle-Bu is the institute that churns out the most postgraduates. Both we cover both undergraduates, the medical school, the dental school, nursing school, school of hygiene, the public health, the postgraduates for the nurses, the perioperative, and all those are situated on the Korle-Bu campus. And then the allied health professionals, their schools are also here. And then postgraduates, we training all the physician specialists and surgeons and various other specialties. And so it will be good to have some learning and skills center as a facility to support learning. And of course, even if you are not in any of the undergrad or postgraduate program, as a healthcare professional, lifelong learning is one of the things that should be part of you. You should always be ready to find out the latest information, latest technology, latest ideas, latest treatments, etc. So that you can offer the best for your patients all the time. So we want to, have this kind of facility. So that's one of the projects that we'll be launching towards the end of September, and we'll be inviting people to support us in this way. Then it's another project we also want to take. I'm sure your station has mentioned it before, the endoscopy unit, because it's one of the units that is very busy and should be doing a lot more, but because of the constraints of where it's located now and so the equipment, we want to. So we have gotten plans and located land to do a new endoscopy unit, but then it's going to be twofold. So one floor is going to be endoscopy unit, the other floor is going to be a day surgery center, because we do have a lot of patients that have to come in for some minor surgery. Sometimes just a biopsy, like maybe taking a sample of a tissue to go to the lab, or maybe just a small growth that can be removed, and the person doesn't have to sleep in the hospital. The person can go home the same day. But the way it is now, they end up coming in to queue with the inpatient or those who are coming for major case. So sometimes, if the major case, delays, or in surgery, they have to be in there for a longer period, then the day cases tend to get cancelled or it inconveniences them. So we thought that it would be good to have a day surgery unit where some of those minor processes are taken to, and they can be processed very quickly, and they're in and then they're out. So it will be more convenient to have a higher turnover, and I think it will be better for our patients.
So this is the same endoscopy unit that got flooded recently, and obviously hit the headlines.
Yes. So that the location of the endoscopy, even the physical size of it and the access, because if you have to even bring in patients and ambulance, you can see this is like in a cul-de-sac. So it's the location itself and the physical space it occupies. We looked at it and we realized that we couldn't really do any meaningful expansion of it, because the new psychiatric block is just a couple of meters to the side, and then it's where it is. There's not really much space to expand it, so we thought that it's better to build a new purpose-built unit, and so that is the plan. But then the plan has been made such that it also encompasses. So that ground floor will be the endoscopy unit, and then the first floor will be the day surgery unit.
How much is this going to cost you?
So the estimate is also going to cost about between $6 and $7 million.
Where are you going to get the money?
Yeah, so we have reached out to some corporate entities. So we've engaged some of the players within the oil and gas sector, and then so we're hoping to. One of them is leading the charge to help us to put together a group of them to support this project as part of their corporate social responsibility.
Okay, and obviously this sounds like an urgent one. I mean, considering that we saw the pictures, it didn't look great at all. What timelines are you giving yourself to get this at least started?
So we're hoping to lock in the financing before the end of the year. A few of them have pledged that made some strong commitment to this project, but then we want to make sure that all the financing is secured and the project can be rolled out.
Okay, let's talk about the obvious challenge with the dialysis unit. And the last week when I spoke to you, you made some progress there. Yeah. You had to close it down for a while, but you've reopened now. Yes. What has changed? Okay,
so what has changed is that we've secured, our consumables have arrived, and we secured on site. So we if you care to know, two containers arrived at the same time. Okay, so we had already, one of them was supposed to have arrived much earlier, and then followed by the second one. But because the company that we're dealing with having problems with shipping, so these items were ordered last year. As soon as we paid our, thankfully the government gave us the 4 million cedis, which was the financing gap that we had at that time. And so once we secured that and transferred the money, we made the order from last year.
I mean, the same 4 million that was promised on the conversation that we had in our studio during the dialysis crisis campaign to get people to help.
Yes, doing the
so that was paid to help you clear this.
Yes, exactly. So once that was cleared, then we made the orders. And so this should have arrived by the first quarter of this year. But I didn't. But we were told that they had been packed ready, and it was just a problem of the shipping line. So there were a lot of emails back and forth. Eventually, the containers arrived at the port in, I think, and in July. Okay, and unfortunately, there was some issue with the paperwork because the shipping line got the paperwork wrong. So they had to do some corrections. So we couldn't get it released to us. And so a bit of back and forth. So that's what caused the delay. Because, but from our projections, I mean, if things had gone the way we had expected, one, they should have arrived earlier, but they didn't. But even at the time they arrived, if not for some of these delays, which were beyond the immediate control of the institution, thankfully, we were also grateful to the Ministry of Finance. You know, the Minister and the Honorable Abner Sasari were very helpful in facilitating our the waiver letters for us so that we could clear them with a duty waived. You know, so once we've secured them, they are on the ground, and you know, the normal service have resumed. But then, because of what we experienced over the period going forward, we've had a renegotiation meeting with the company that supplies us the consumables, because last year, I'm sure, if you collect, during the discussions, we talk about some of the contractual issues that regarding the supply.
We're bound to go to them and them alone.
Exactly, because of the contractual arrangement, and that there were some outstanding machines that were supposed to have been delivered, you know, I think around 2017, 2018, that were still not being delivered. And so the relationship was not a very, you know, good one in terms of, we had been making a lot of effort to try and get them to send, but they were being stonewalled, as it were. And so I had even discussed this with the Honorable Minister of Health, and he felt that, well, either we have to go to the parent company to, you know, make our case, and also, so those were the kind of plans we were taking. But then, thankfully, there were some changes in the leadership of the organization. So those that were in charge of, you know, West Africa were changed, and then the new team are more switched on and more clued up and sensitive to our issues. And so there was a visit. One of them is actually in town, actually conducting training for our staff at the arena as we speak. And so, I mean, they have, agreed that we've not been treated fairly. And so the outstanding machines, 30 of them are going to be shipped into the country.
When are they hoping to
so
do
we're
this?
hoping that they arrive before the end of the year. And so this will be in addition to what has been promised by the ministry. So that would help us to now open up fully, because we actually have a lot more places where dialysis can happen. So the urology nephrology
So it comes down to the question of space.
Yes.
So you are now expecting 60 dialysis machines if the ministry keeps its word, and they also.
Yes, but then the question of space is not an issue, because the urology nephrology center of excellence has got a space for 30.
Okay.
We also have the dialysis cabin has got space for 18 or so. There are only 10 there now, and then we have the old urology center, which the old dialysis center, which is on the first floor of the medical block, which is totally run down. So that is going to be revamped, and so the rest of the machines will be there. Because once we have that, then what it does is that it gives us more degrees of freedom in terms of how we sort out the patients. But what tends to happen is that each patient that comes on dialysis will be on the machine for 4 hours. Now we have between 230 to 300, patients who are on dialysis. Each of them is coming for a minimum of 2 sessions a week. So you can imagine, and if each person is on the machine for about 4 hours, you can imagine the kind of queue that happens. So it means the staff have to work around the clock overnight, and what it also means is that if a machine has to be, serviced, you can imagine how it impacts immediately on the processing of patients. Mm. And so once we have more machines, that means that doesn't become an issue anymore. The other advantage to give us also is that it will then free up, and you can put some machines on standby all the time, so that in case you have a dire emergency coming in, they can go onto a machine immediately and get sorted, instead of having to wait for somebody to finish their session before they are put on. Then the third thing that I'd like to also bring out is that the machines that we are expecting from the side of the ministry are such that they are the open system. So it means you can source the consumables from a variety of places, which means that when you have a supply chain problem with one supplier, it doesn't cripple the whole system, as was the case in the past.
Mm. And I'm curious about the government 30. Have we bought them already?
Yeah, so yes, the procurement process is being undertaken. So
okay.
I just have to double check exactly
what the thing with government is often there's a gap between what is promised and what is actually delivered, and expectations can be very high, but then it doesn't come. I mean, what's your assurance level from the ministry?
I believe that the ministry is very, very serious, and I think that the current Minister of Health is quite very switched on, and I think the last time we met and discussed this issue, I think he believes that these services should be decentralized or rolled out across the country, because everything doesn't happen in Accra. There are patients across all the different parts of the country who will need these services, and so he's looking at coming out with some comprehensive nationwide plan so that these services will be brought to the doorstep of people around the country. And so I think that's at the right time. I'm sure he's going to come up with some program like that to address the issue in a serious manner. And I think it's going to be comprehensive, involving even training of personnel, maintenance, and all those supply chain issues.
But also, you told me last week some fascinating positive progress around a new treatment for dialysis that would actually allow patients to treat themselves at home.
Yes. So sometimes there's a saying that every cloud has a silver lining. So the silver lining in all these issues that happened from last year to now is that there's one of the options for filtering waste products from the blood of anybody. Is peritoneal dialysis. Because what we're talking about dialysis, we all talk as if there's only one way of dialyzing, or that's one way of getting rid of waste products from the body of somebody. So the hemodialysis is one method where your blood vessels are hooked up to a machine, and your blood goes to the machine kind of filters out the waste substances from your bloodstream. But then there's another way of doing it, which is peritoneal dialysis. So what happens is that a catheter, a tube, is fitted into your abdominal wall. Okay, so it is clipped off. Okay, so that when you are ready to undergo dialysis, what you do is that you introduce a particular type of fluid in a particular volume. So you introduce it into your abdominal cavity. So it sits in the abdominal cavity for maybe 30 minutes, 1 hour. Okay, and during which time an exchange occurs. So the waste substances in your blood gets through a process of, I'm sure osmosis, in the diffusion. They diffuse into the the fluid. Okay, so when that happens, okay, after a while, then you then open the valve, and then the fluid that's is let out, is drained out, and then you are good to go. So patients are trained to be able to do this at home themselves. So they are given the right coaching supervision so they do this because if you don't also do it carefully, you can end up getting very bad infections. So once that is done, they do it themselves at home. So they are given the quantity of fluids, so they know how to administer it themselves, and then every now and again they come for checkup, check their blood levels to make sure that the ureas and the creatinine normal and so on. And so, but why we're not able to provide this in Ghana was that we didn't have access to the fluids, because the fluids are quite heavy. Shipping them, looking at the quantities that are needed per patient, shipping them was going to be a huge issue. The transportation of it, then the cost becomes prohibitive. And so and during this period when these discussions were going on, one of the pharmaceutical companies in Ghana, that is Atlantic Health Sciences, Life Sciences, they came on board and they expressed interest, and so they have actually developed the fluid and able to produce the fluid. And so they are going through the FDA approvals and the institutional review board approvals to start like some kind of local research with it to see whether this will work in our setting. And so once the results are validated, that means that this is something that can be potentially rolled out to patients in this country.
And what timelines have they given you on this?
I expect that some of this will take a little bit, but I'm sure that probably, hopefully by the end of next year, we should have some definite results in that direction.
And that fundamentally will allow patients to treat themselves at home.
Exactly.
They don't have to come to the hospital for dialysis anymore.
Exactly.
That will be groundbreaking indeed.
Yes.
Would it be costly or would it be affordable?
Yeah, so the idea of having it manufactured locally is to make it affordable, because in the long run, it actually works out cheaper in the long run.
Yeah. Let's talk about Korle-Bu's financial health.
Yes.
Are you in good financial health?
We are managing. I think there are, as for every institution, there are some challenges. That because we are a teaching hospital, and one of the key things about teaching hospital is that you'll be happy if you just manage to break even.
Are you breaking even?
We are trying to.
Or you're making losses?
Okay, so some departments are doing well, some departments not so well. So
overall,
we've had to. Overall, I think we've seen some significant improvements over the last few years, because we are trying to enhance our financial efficiency. Because now we are treating each department as a business unit. But then one should also know that there are some departments that will always run at a loss. Because
give me an example.
Let's say the chest clinic. People with chest tuberculosis, usually people from very poor, low economic background. If you have places where, let's say the fevers unit, for instance, where people with very infectious disease, HIV, hepatitis, all those kind of conditions come to. Some of those places will not run at a profit. Okay, and so that's a challenge. Then, in Ghana, we see health as a social service. So Korle-Bu is the only facility where, hit and run patients just come, be dropped at our doorstep. And they are Ghanaians, so we can't say that, well, you don't have money or you don't have any, so go elsewhere. So we take them in and we treat them. But then when they finish and they cannot afford to pay, what do you do? So and so that happens a lot. So every month on month we see a long list of people who have come in, have assessed the service, they've had very complex surgery, etc., but they cannot afford to pay. So what we do is that we help social welfare to, we get in touch with social welfare to investigate their backgrounds to see whether somebody can come in and make a guarantee, or maybe you can make some part payment and split installments, etc. So but there's some that, to be honest with you, look, there's no way they can pay. So sometimes we have to write it off. But sometimes when we do that, then the auditors also come and hold our necks for causing financial loss. So it is so we're working a kind of tightrope whilst trying to also make sure that these things do not affect quality. In fact, that is why we very much welcome the philanthropists who come to our aid, in terms of, so there are a number of people who, on the maybe occasion of their birthday, or if they are celebrating a significant event in their lives, they'll come to us and say, look, do you have any patients who cannot pay their bills? And then they come in and pay for them to be discharged. And that's how we manage to kind of cut down on our losses. But the truth is that if we were to try and recover everything, there'll be a massive social upheaval, because the number of people who come in and are treated and lives are saved, you have no idea. So if, people come in and they cannot get that kind of help and their bodies start piling up, I don't think to be
overall, though, what does it mean for the...
And even for dialysis, for instance. For dialysis...
It's subsidized.
Dialysis, yes, because at the moment, dialysis, for every session of dialysis that we are undertaking, we are actually under recovering. Because
by how much now?
By a little over 300 cedis. Because when we did the numbers, what it costs us to provide dialysis for each patient is about almost 800 Ghana cedis. And so, the fee that was approved by Parliament is 491 cedis. So it means that for each session of dialysis, we are under recovery. So this is how the deficits build up. And so we have still engaged some philanthropists who have promised to come in with some funds to help us to show up the difference. But the truth is that because of the large numbers that we do, because we are doing about average about 2,000 dialysis sessions every month. So we're doing 2,000 and you're recovered by maybe let's say minimum conservative estimate, let's say 300 cedis, for instance. That's 600,000 cedis under recovery every month. And that works out to 7.2 million cedis every year. So that is the extent of deficit that we are just by.
So you're accumulating 7.2 million cedis every year.
Yes.
From the under recovery in dialysis treatment alone.
Yes.
Give me your assessment of the NHIS intervention that they announced recently. I was just reading just before I came here that in terms of the disbursements, the Comfort Teaching Hospital is getting the bulk of that money. What's been assessment of that in terms of helping?
Okay, so the NHIS has got a criteria for that's going to cover for those under 18 and above 65, and then also it's going to pay for 2 sessions of dialysis every week for those between those 2 sessions every month for those within that bucket. But you can imagine that the patients, so it's a good intervention because, like I said, it's better than nothing, because we are at the point where there was 0, and then now we've got in this situation where some people are being covered for all their sessions, and then a certain number are getting 2 sessions of dialysis subsidized every month. So every little helps, because for the patients the renal failure patients, they have to find money to pay for every session. And of course, our patients in Korle-Bu are not used to this. Okay, and let me explain. Because from 2017 to 2023, our patients were on this First Skies free dialysis program. So 230 of our patients were on this program. And so for the last, from 2017 to 2023, they were not paying anything at all for dialysis services. But that's at the time this was started, and it was the session of dialysis cost 380 cedis. And at that time, that was equivalent of $100 per session. Although in terms of dollar equivalent, the price per session has come down. So you can see, but if you benchmark $100 per session, for instance, in 2017, now how much is $100?
Yeah.
And then we are charging 491 cedis. So it just tells you the extent of the under recovery. But then we are not aiming at making a profit. We are aiming at trying to just break even, so that at least you can keep the service going. So that is where.
But you're currently making that loss of, I think so.
Exactly.
Is the National Health Insurance Scheme paying you though? Because once they cover it, they need to pay the money.
Yes. So they started the reimbursements have started coming in. So every month they look at the number of patients that have been done, and then they pay that amount. But then the challenge now is for the individual patients, because for some of them they're finding the financing. Although NHS is helping, and it's a very good gesture, but I think the NHS also has to be careful what they take on, because it needs to be sustainable. And so I think as the finances of the country improve, and we have more means of extra income, etc., then probably it will be able to be expanded. I mean, so looking at the NHS in general, you remember that some time ago we didn't have some of the childhood cancers and other breast cancers covered, but now they are covered. So I think that they do their actuarial studies and see what is feasible, what can be done and what cannot be done. And so I think that forms that. So for our patients, what we're doing is to see how else we can also support them in terms of meeting this cost or getting some support for them.
And talking about the challenges you're facing, talking about the dialysis, talking about the endoscopy unit, there's also the surgical block and the lift there. I mean, the reports I've seen today suggest that the lift is broken again. Yeah. What's the update on that?
Okay, so yes, the surgical block has got 2 lifts, but they haven't mechanical problem. Initially, there was a service contract with the firm that installed it, but then they were not making good on their in terms of their side of the bargain. So we had to change the vendors who have also kept it going for some time. But we, from last year, we noticed that there was a frequent breakdown of the lifts. So we decided to procure new. So actually we are in the procurement process trying to procure new. But we're told that for this kind of lifts, you even from the time of ordering to installation, it takes a minimum of about 6 months. That's what we're told. So in the meantime, we've engaged some other experts to come in quickly and see how they can, revive the one that was functioning. So we are getting that one overhauled and then a new one, because these things come at a cost.
So, how long has it been broken now?
Oh, just about I think from over the weekend.
Okay, and when do you hope that the engineers will look at it?
They are actually working on it now.
And as we speak?
As we speak, yes.
Have they given the timelines when it will back up and running?
So far, we are hopeful that they should be able to give us some solution within 48 hours.
Within 48 hours?
So that's what our expectation is. Yeah. But they are going to actually come out and give us a proper report. So what we've done is to in order not to kind of affect patient care, we've redesignated the emergency. So we've cut back on the elective cases, and then the emergencies are being processed because we have other theaters. That's also the good thing of not working in one block. So we have several other theaters around the coma. So we've redesignated some of the other theaters for the emergencies that are coming. So from the accident and emergency, then we move to those theaters, and then the other wards that don't need lift. In fact, they are the ward H, ward I, and so their lift is working. So the patients are being channeled through that section of the hospital.
But in the meantime, you've halted elective surgeries.
Some of the elective surgeries. Yes. So there are some elective that also have because they are urgent, But then just to reduce because because this is not the way we are operating normally. So since we have had to make some adjustments to the service, we are the code. I mean, if you let's say have a lump of fat on your wrist or something, that is not something that would have any impact if it is done this week or in 6 months. It's not going to really make any difference. So those kind of cases are being rescheduled, whilst the urgent ones are being routed.
But in that building itself right now, you're not using it because of the work being done right now to try and fix the elevators.
We're using it, but then we are not taking new patients, and then so the basically
the surgical blocks is not taking new patients until they fix the lifts. Yes. Okay, I want to take a quick break. When I return, I'll talk to him about his own tenure as a CEO of the Korle-Bu Teaching Hospital. This is a very, very difficult place for CEOs in the past. How is he faring in this particular place, and what has he really done to leave a legacy? We'll assess that when we return. And thank you very much for staying with us. This is PM Express. My guest is the Chief Executive Officer of the Korle-Bu Teaching Hospital, Dr. Opoku Ware Ampomah. Doc, thanks for staying with us on PM Express. How long has it been since you took the helm?
It's about 3 years and about 10 months.
Okay. If you were assessing yourself, and scoring yourself, and you're also a teacher, so it's good to ask you that question. On a scale of 0 to 10, where would you place it?
Well, I wouldn't give myself a score. I think it's the people out there and the patient who serve that would score me. But,
specifically, what would they say if I go out there and talk to them? And what are the key, very verifiable things that they will look at to do that assessment?
As it depends on who you are speaking to, but I can only talk about what I'll be able to do. with the team within the time that I was privileged to serve so far. So the number of areas that we looked at. So we looked at our stakeholder satisfaction, because at the end of the day, it's the patients that are at the center of everything we do. So trying to see what are the key concerns of patients and what can we do to improve upon the satisfaction of patients. The same thing, the stakeholders are also, our bosses at the ministry, government, and then, the staff themselves are also the key stakeholders. Even those who, we do business with, our suppliers, etc. They're all key stakeholders. So you have to make sure that you manage, all these people and try and do your best to satisfy these key stakeholders. But even if you take the kitchen, for instance, I mean, we also did some changes in the kitchen. The new leadership, they are doing very well in that regard. And between 2022 2023, for instance, we were making, although the food inflation, there's food inflation. 2023, and then the new leadership, the food quality went up significantly. But then our actual, in terms of the cost or the amount we were spending on food actually came down. So we're making savings of around 200,000 cedis every month on food purchases, despite the fact that the food quality had improved and the fact that there was inflation in terms of cost.
How did you achieve that? What changed?
So change in leadership, change in supervision, also making sure we are tracking things properly, and so that was it.
And then one of the things, since talking about your tenure, the infrastructure.
Yes.
I know that we started by talking about 100, years since this establishment was founded, and you're using it to drive change and getting people to invest. But in the last 3 years, what have you done to try and upgrade infrastructure?
Yeah, so we've done quite a lot. So in terms of equipment, we've introduced new equipment, new machines. We've introduced the cardiac catheterization lab through the instrumentality of the SSS, the Vice President and the Bank of Ghana. We've done that. We've also introduced a fluoroscopy, service which hitherto was not. We've not had fluoroscopy for quite a number of years, but that has been introduced. And so there's a lot of new equipment. We bought about 15 ultrasound machines for radiology departments. We made sure that we revived the MRI and CT scan are functioning. We've also introduced a new 128 slice CT scan, which is in the Urology Nephrology Center of Excellence. So in terms of the big projects, the FEVES unit has been had the total, redone totally, and the infectious disease center, and then the new treatment center, which is also 50 bed, has also been done. The psychiatry unit has got a new block. The Urology Nephrology Center of Excellence, which is 100 bed facility, 38 million euros has been done. The diabetic center has been, rehabilitated. If you do the orthopedic wards, Ward D, Ward H, Ward I, they've all been refurbished. So in terms of infrastructure, there's a lot that's going on there. Through the instrumentality of the Atlantic Bank, we have the new patient waiting area in front of the children's block. The pediatric oncology unit is coming up behind the children's block. Essentially, the First Lady, Mrs. Rebecca Kufuado, also helped us. She literally sponsored the whole thing, put up a new hostel for children with childhood cancer. And it's called the Rebecca Kufuado Sunshine Hostel, which is on the Industrial Park. So that has also, been done. So, these are all projects that have happened within the last, 3 to 4 years. And so, if one can look at that and see that at least with something that's
no bed syndrome then solved.
Let's say the no bed syndrome has improved significantly, but to be able to solve it, it doesn't depend on just Korle-Bu, because if we do not improve the capabilities, the capacity and the capabilities of the surrounding institutions, peripheral, the institutions that feed Korle-Bu, there's no way Korle-Bu can cope with the numbers of emergency cases, because you only have so much space in the emergency room. And the truth is that most people talk about no bed, everybody imagines that it's just a physical bed, but it's not just a regular bed. You need a bed that comes with certain minimum equipment and certain minimum personnel, because in emergency rooms for people who are seriously sick, need close monitoring, and prompt diagnosis and things like that. So it's not just a regular bed and put them somewhere and then just walk off, but you need to, so that's what we are talking about when you talk about emergency room beds. But then one of the things also that I think we've been able to achieve is also to try and improve our staff motivation. One of the key things we've done is to introduce 100% Medicare for our staff, because previously then when our staff access healthcare, they have to pay for it themselves.
Nurses and doctors who are working here were paying for their own healthcare when they fall sick and had to be treated by an institution they're working for.
Exactly. So of course that is a very, very demotivating thing. So my predecessor started 50% coverage, but then we've ramped it up to 100%.
So if you work in this institution, you get healthcare for free.
Yes. So we are the first government in health institution that has introduced this package. And we also recently just introduced the employee assistance program, which is also a support service for our staff, because some people need legal advice because they are taking all these killer loans and encumbering themselves with all these financial constraints. So legal advice, some need financial advice, some need legal advice, some also suffer from some addictions, etc., that they need to be brought out of and all that. So we have created this employee assistance program, and actually we are the first public sector organization in the whole of West Africa to have introduced an employee assistance program. So in our own way, we are making.
Talking about personnel though, how is the brain drain crisis affecting you?
Yes, so
doctors, nurses, or eager to leave and leaving.
So of course, once there are push and pull factors. So once you have the situation where there are better conditions being offered elsewhere, then people will, elect to move to those places because they feel they can make more financially. And so that is something that is there. But then but paint the picture for me. What's the current situation with that? Are your doctors leaving and nurses leaving and leaving gaps for you? Yes, we've had a number of doctors leaving. To answer you, we had a number of
significant enough to affect your ability to deliver the healthcare with the fixed effectiveness.
So far, I'll say we have the numbers that have left. Are concerned because it's a trend that we are concerned about. It's not really there because at the moment, I think we still have reasonable numbers of staff to work with, but I think we need to do something soon to stem the tide, so that we can retain the bed. Because for us, it's not actually the absolute numbers leaving; it's who is leaving. Because if you have,
who have you lost?
Exactly. Because if you you have if you are to look at it in terms of the total number of nurses, probably you may see that the difference may not be that much. That's significant. But if you look qualitatively at who is leaving, because if you have, let's say, an ICU nurse of, let's say, 15 years plus experience, when they leave, it's like you have a whole institution.
Are you currently losing that caliber of health professionals?
Yes, we've lost a few of those. And so then that's why I'm talking about the trend. We've lost a few of those. But then we're also trying how to retain that stuff, because one of the challenges that our nurses were having was...
Pardon me, you should clarify. So the trend is that you're losing this high caliber health professional in Korle-Bu? Is that the trend you've noted?
We've lost a few of those.
And it's become a trend you've noted that you want to stem?
Yes, exactly, because and that's a trend across the entire country. So it's not just a Korle-Bu thing. It's a trend across the entire country, even the I would say even the continent. Okay, so there's always will be that drive, but then it's what we do. So for us in Korle-Bu, we realized that one of the reasons why our nurses were disaffected was the fact that when they got to the rank of, let's say, principal nursing officer, their progression to the higher grades was constrained. So last year, for instance, we created about 110 new deputy chief nursing officer positions. So that allows those who have been marking time at the principal nursing officer level to advance in their career. And then even just a couple of weeks ago, we've also decided to also expand the chief nursing officer grade, the number of positions in that grade, because if you look at the size of Korle-Bu, for instance, let's say the size of the surgical block is the size of about, let's say, the whole teaching hospital in terms of bed capacity. So, but the whole teaching hospital will have a number of maybe chief nursing officers there, but if you come to Korle-Bu, we'll just have one. Okay, so it means that if for those who have many years of experience, they cannot move up the career ladder because of that bottleneck. So we looked at it and looked at the fact that if we are to equate it like for like, then it means that our nurses are being structured. That was one of the reasons why people were getting disaffected. So sometimes, even if not that they are leaving the country, they want to transfer to another facility so that at least it enhances their prospects of moving up, along the career path. And so that has been done. So we see that so that has made them a bit more.
At the national level, though, and very finally, what would be your recommendation to deal with this crisis, this brain drain crisis?
I think there are a number of things. So, number of measures. What we've also noticed is that when you are able to support people in terms of career development, because not everything that is money, but when you're able to support people in terms of career development, that's what we've done intentionally. We've introduced a 5-year training plan where we are targeting particular subspecialties and getting people to train in those subspecialties. So when people are, they have fulfillment in their careers in terms of they know that they are meeting a certain particular need. It takes a lot for them to work, because they feel that they've attained some self-actualization, they are fulfilling a certain role, and also more opportunities open up for them once they are in that niche area or that subspecialty space. And so, at some of the units, we've sent doctors abroad to go in and take subspecialty training and things like that, and they do come back. And when they come back, they contribute meaningfully because they know that they are at the top of the game and they are impacting meaningfully. So that also is one of the things that look about. Of course, there are genuine things like the salary levels, etc. So I'm sure you know when you go abroad, for instance. The salary of a consultant, surgeon in the UK is higher than the Prime Minister's salary. so that's the kind of context, So I think I'm not saying that we can have the same thing, but I think we need to look seriously at the conditions of service for health workers in general. So, and I think that if that is looked, I think that would make a big difference. The other thing is also looking at other packages. So one of the things like staff accommodation. We realize that one of the things that is affecting our staff seriously is the fact that, even if, let's say, you have a modest salary and then, your outgoings are reduced, it helps you to, keep afloat. So one of the things we are looking at is staff accommodation. So we, at the moment, have a number of proposals we are considering, which will be sending up to, Ministry of Finance for consideration and hopefully for approval, so that we can improve the number of accommodations for our staff, because some of them complain about the fact that they live across town and the commute distance, and all that affects their output and their drive, and also childcare issues. So one of the things that we are doing for the Korle-Bu 100 is to put up a staff creche. So it's going to cost about $600,000, so equivalent. So that's one of the projects that we have coming up, so that our staff who are in the child producing age or childbearing age can have somewhere for their children to be taken care of. So those are some of the things that we are that we are undertaking. And of course, but one of the key things also that we've managed to do over the last few years is also improve the quality of our data and the quality of our M&E, because previously we didn't have a formalized M&E plan. So now we have a monitoring and evaluation plan, so that we're holding ourselves accountable. So that transparency, so every department will report every quarter on its performance. Its key inputs, outputs, everybody's giving KPIs, key performance indicators to that we measured by, and then every year, every department will be giving targets. Because previously we're not even collecting this data, we didn't even have any targets and things. And so now we are, putting that. So that system has now been, entrenched, within our organization, so that now that has now become part of it. And then we didn't just leave it at that, but we also involved the middle level, the lower level staff. So, and we trained them in how to validate data. So if you came and maybe you are the head, but if you came and gave a presentation, okay, I've done ABC, you were there, a number of people that we've trained who will come from another department, we call it a peer review system, who will come and look at the data and validate it. So see whether what you present really is the fact, or it's been, cooked, as it were. And when we did the data validation for Korle-Bu, for instance, in mid-year 2021, the data validity rate was 18%. So what it means that whatever data that we were working with at Central Administration was used. You can't really plan properly with that kind of data. So with all the improvements we did, end of 2021, we were about 34%. Mid-year 2022, we moved to 51%. Then we moved up end of year 2022 to 53%. And then 2023 we moved up to mid-year we moved up to 68%. Then we did 72% at the end of 2023, and then mid-year 2024 we are at about 73 or 74%. So at least that is on the things are going the right way. So it means now, and we also because we also monitor indicators, we can tell which parts of our service is not meeting the required demands, and things like that. We've also instituted
so those who don't meet the KPIs, what happens to them? Very, very briefly.
Yeah. So if you don't meet the KPIs, the directors would engage you, find out where the challenges are at this moment, because it's early day. Because we just started the system just about 2.5-3 years ago. So it's like we're all learning. So it's kind of a learning process. So we don't do it like in a punitive way, but then we also share the results transparently, so everybody sees which department is doing well, which department is not doing well. And we told that we could do the rankings. So and so that has also brought in some positive competition among the departments, to try and outdo each other in terms of performing well for the patients.
Dr. Opoku Ware Ampomah, thank you very much, and all the best. The challenge before you, it's quite monumental, and happy 100th anniversary.
Thank you.
Enjoy the rest of your evening.